Good morning, ladies and gentlemen. I'm Ben Fong. Welcome back. And sorry to be a few minutes late because of the weather, and a few of our speakers and friends got wet in this weather. I'm very pleased to introduce our third keynote speaker, Professor Eleanor Holroyd, who is an old friend of Hong Kong and the university. And she has kindly agreed to accept our invitation a few months back to come and share her experience in her current position. She is the Associate Dean of the Faculty of Health and Environmental Sciences of Auckland University of Technology in New Zealand. And she's a nurse by profession, and she's got a PhD in medical anthropology from the University of Hong Kong. She's also a professor in nursing and co-director of the Center for Migrant and Refugee Health Research. She's got 30 years of experience working in the international university sector, mainly in Asia, including our university here, National University of Singapore, and the Hong Kong U's Shenzhen campus, as well as Australia, and more recently in East Africa. And the focus of her research and teaching on health equity, human rights, and social justice has spanned the area of nursing, public health, and social sciences. She's got over 150 internationally co-authored publications focusing on underserved populations using a human rights perspective. She's got prioritized co-designs in her grant application and NGO collaborations, both internationally and regionally, building in a long-term social impact measures. Without further ado, please welcome Professor Holroyd in her keynote speech on Tourist Utopian Sustainable Healthcare, Lessons from New Zealand's Collaboration, Cultural Competence, and Community Empowerment.
Thank you very much. Thank you. Thank you. Good morning, everybody. It's nice to see a lot of familiar faces and friends and colleagues from the past, and really importantly, ex-students who are now doing some awesome things. And I'd like to start, similar to other speakers, by saying a really big thank you. Thank you to the organising committee. You've done an amazing job. Thank you for inviting me here. It's always a privilege and an honour. And it's great having had yesterday to hear the shared stories of looking back on 25 years or more of engagement with Hong Kong. Some of the issues remain. There's some great strides happening, and it's great to see the policymakers at the table. And I just want to congratulate Anthony again on putting all that together, and the committee on putting that together, and also just the responsiveness of the policymakers yesterday. And I was very impressed with the social media last night, how quick everything was happening. So again, a great privilege to be part of it, and on behalf of myself and my university, thank you very much. I'm going to talk mainly today, because I no longer work in Hong Kong, just about some of New Zealand's response to public health capacity building and strengthening, and some of the issues around cultural competency and transparency and building public trust. And I'm going to keep my talk deliberately short, more visual, just to stimulate some conversation, and I sort of welcome some discussion at the end. New Zealand is located in the South Pacific and sees itself as a strong Pacific identity. For years, we had many populations coming in from the Pacific Islands. In fact, New Zealand was a protectorate of many countries, and those countries eventually got independence. And as a consequence, we have large Pacific populations living in New Zealand, as well as a substantial Indigenous population in New Zealand. About 15% of New Zealand is Maori, and about 10% is Pacific. And in our largest city, Auckland, we have larger numbers. islanders of Pacific and Maori, thank you, and increasingly migrants and increasingly refugees, many from Afghanistan. We're also subject to many of the issues that Hong Kong went through in lockdown, and also climatic change is a big part of what we live with. We've recently had a number of floods as well. Yeah. So some unique features of the New Zealand healthcare system include a universal tax-funded national healthcare service, and one of the first countries in the world to do so. And I wasn't aware till yesterday, but reasonably uniquely, we have a universal old age scheme. Everybody over 65 have a non-means tested pension, whether people have just arrived or been there a long time, intergenerational, which is paid out to all New Zealanders at 65, as well as the winter heating bill. So we have some quite interesting welfare policies from reforms of the 30s. We also have a founding document, a Treaty of Waitangi in Maori, which is the Indigenous language and now taught as compulsory elements in schools. Te reo is the word for Maori language, Te Treaty o Waitangi. And we're starting some very innovative Maori health services that cater for the needs of Indigenous populations. And these are not dissimilar to models for all Indigenous populations. So I'll just talk to that in a little bit more detail as we go through. We also have an accident compensation scheme. So any accident in the community or home is automatically covered for healthcare and time off work, and there's a series of steps around that. And we've had some quite groundbreaking health reforms lately in response to Health Future think tank work going on called Te Whatu Ora, which means the weaving of wellness, in 22, and this year we're playing out the construction of the new healthcare system. We also had some new policy on smoke-free New Zealand, so I hope to cover most of these just as an overview, just to stimulate conversation. So our founding document, the Treaty of Waitangi, signed in 1840, was an agreement between tangata whenua, which means people of the land. Whenua is the land, and it's also the word for the umbilical cord that joins our baby to its mother. And tangata treaty, the people of the crown, and are non-Maori. And there's 4 specific articles in the treaty, and this document is central to all our health policy, our educational policies, our housing policies. It's embedded in universities, school systems, hospital systems, and in all intersectorial work. Not perfect, but I'll just go through some of the key principles because it's quite important to grounding for the rest of my discussion. Article 1 is koanatanga, which means that the chiefs exercise full authority, which means mana or respect, over land and resources and part of the wider community. At the same time, Māori would retain sovereignty. Article 2 is tino rangatiratanga. It promises that Māori will have the right to self-manage resources, including the health and the mararanga they wish to retain. And that also emphasises status and authority. Article 3, orangatanga. The Crown promises Māori the benefits of protection and full citizenship and the right to equity for Māori alongside other people. And the last article, which is around the ecological environment and the spiritual well-being of the land, of the people, of the animals, of the planet, really. Spiritual practices and well-being, a wairangatanga, a defining characteristic and determinant of good health. Yet, in the last five decades, indicators for Māori and indeed Pacific health have remained inequitable with those for non-Māori and Pacific. So, for example, cancer deaths have risen across the lifespan for Māori males and females, and also other indicators such as cardiovascular and end-stage renal disease, hospital admissions and mortality rates remain lagging. So we have a gap or a system of inequity around Māori health outcomes in New Zealand. And there's some early work done in the 90s by Mason Jury, who was quite seminal in looking at models of healthcare that drew on indigeneity and worldviews that intersected with the environment, and not dissimilar to some of the work that's been taking place in planetary and One Health movements, was the Te Whare Tapu Whā model, which recognises the interconnectedness of physical, mental, spiritual and family well-being. It's very much holistic, and it's looking at a comprehensive approach to healthcare delivery and looking at all the systems of wellbeing that can better meet the diverse health needs of communities. Whare means house, and you can't have a house without each of the pillars representing a key structure in supporting well-being and community and health optimisation. So there's the spiritual, the taurua, the mental and emotional. There's also the family, which is called whānau, and then larger groups, iwi and hapu. And then there's the land, grounded in the environment, which, considering discussions on sustainability and climate change, become quite pivotal. And then there's the physical. And this model has evolved on in recent years to underpin some of our new health reforms and our future thinking around that. Just to emphasise, because I was asked to talk on sustainability and the land in terms of the environment being central to well-being, Māori values emphasise whakapapa, which is the connectedness to your natural environment. In all our meetings at work and in the school, primary and secondary school system and the health system, we're commonly introduced by our key landmarks that we were born there, our mountain, our river, our ocean, and how we came there, and also our pipiha, the generational ancestors, so we have a sense of where we're coming from and going to. And in terms of whakapapa, that emphasises the connectedness to the environment and managing sustainable resources for the future. Kaitiatanga, the Māori community is seen as environmental people with a responsibility, a kaitiaki, or a guardian for the land. And then whānau ora, which is the community around. And the land is part of that community, as is the air and the water, the moana and the water, and the realm of planets and ancestors. We recently celebrated Māori New Year. Jacinda Ardern made a public holiday for Matariki, which is the Pleiades, which is around the remembrance of life past, which was a few weeks ago. Wairoatanga, the spiritual well-being of the natural environment, is equally important to the community. And then for Manarangatanga, the way people relate to the natural environment. And this is an important one, mirrors their internal relationship with the community and how they interact with organisations. So it's centring the treaty values in the land, the people, their past, their futures and their communities. Interestingly, New Zealand passed a groundbreaking law in 2017, and there's been several other rivers declared having personhood status. And this is actually a river that runs in central North Island, the Whanganui River, and it was declared as a living river, where people had a responsibility to be kaitiaki or guardians for the river, and school children are taken there and they talk about their response to the environment and the river's life, and the river has the rights of a person in terms of the right to respect, the right to autonomy and the right to dignity, and incorporates the physical and metaphysical elements. Quite important for a worldview and a larger epistemology in which to situate health reforms. However, as I showed in the earlier slides, in the last couple of decades, Māori remained quite underrepresented in health policies. And a recent review of Māori representation in health policies showed that there was quite a lot of absence. Clearly Māori were at risk because they were behind on a number of, in terms of tangata treaty of health indicators. And there was a Crown lack of responsibility to the treaty articles, and very few of the policies were centering it on what's called Māori knowledge epistemology, vision mātarangi or kaupapa, which is principles of community engagement. And there's been a lot of research out on the benefits of looking at using Indigenous First Peoples frameworks in terms of outcomes for all populations, and the promotion of social accountability, equity and respect for diversity and inclusivity. And then more recently, the octopus, or was used as an extension of the whare, the marae, the meeting house model, to look at the principles of what makes what makes up a person and what makes up well-being, but from a community point of view, Wairoa being well-being, and then whānau being the family, the extended family, and then all the aspects which are linked to mental health, physical well-being, linking to family, key issues around epidemics of loneliness and disengagement and some of the COVID outcomes that have happened, the mind and the life force and the expression of emotion. And a giant squid guided the Great Migration when the Maori navigators came on the celestial journey from Hawaii in the Pacific to New Zealand 700 or 800 years ago. 2022, under Jacinda Ardern's government, there were large healthcare system reforms, and the main principles of this were just returning to the centrality of the Treaty of Waitangi principles and obligations, and all people to assess a comprehensive range of support in their local communities to help them stay well. And that's a very wide range of support: informal carers, families, neighbours, cultural navigators, kaitiaki, guardians of the land. When people need emergency or specialist care, this will be accessible to all, because we do have the tyranny of distance, probably less acute than Australia, but we do have a number of remote communities with not necessarily digital engagement, and also often lack of transport and not necessarily being able to access services. So we talked about services being a postcode lottery, and this is an attempt to address that. And large attention to digital services that will mean that many more people will get the care they need in their homes and communities. A lot of attention to e-health, hospitals, homes without borders, where there's a lot more monitoring in the homes, and digital engagement. New Zealand put in fibre optic quite a few years ago, so actually when the cables have been installed throughout the country, and our connectivity is actually quite good. And very importantly, and I think this is one to highlight, that healthcare workers feel valued and respected and well trained and are happy in their roles. That's come up, it's been alluded to quite a bit about respecting the professions, encouraging people to go into a profession that is respected by the public. The profession gives them a hope and meaning and an understanding, and the community values that. So that wasn't necessarily the case during COVID, so I'll talk to that a little bit. And the main principles of this are equity, which sort of I've outlined in the gap for Pacific and Maori, and increasing numbers of other priority groups. Sustainability, that's embedding population health as a driver of preventing and reducing health need and promoting efficient and effective care. Very much people and whānau centred, empowering people to manage their own health and well-being, and having meaningful control over the services, and treating them as the experts in their own care. So very much a bottom-up approach. And I know a number of the speakers yesterday talked about the importance of bottom-up, listening to the community, listening to the wisdom of the patients and the communities. And then excellence, high standard of care and quality in areas, leadership, innovation, digital enablement to improve services. And of course, alongside these reforms comes workforce issues. New Zealand's facing an ageing workforce, probably similar to Hong Kong. Huge numbers migrating, especially now Australia's opened up citizenship for New Zealand citizens. We're losing our graduates as fast as we can train them. We have an underrepresentation of Maori Pacific in our workforce. We have the highest number of internationally qualified nurses of any OECD country, often on citizen pathways to New Zealand and via New Zealand to Australia. And of course, the underrepresentation of Maori and Pacific in clinical roles, medical doctors, nurses, physiotherapists, allied health, pharmacy, etc., caring, enrolled nursing. Poor health status of Maori, and a recognition of the considerable role Maori play in creating a sustainable workforce, and then showcasing initiatives that empower Maori, and also emphasising the importance of wakapua itea, a healthcare for all. Just to touch on a few other issues during the COVID-19 pandemic, New Zealand was hailed for a while as quite revolutionary in introducing early lockdown, and our bubbles mandate, where people formed intimate bubbles or work bubbles with a number of people, was actually seen as quite groundbreaking in a number of places, and the government held regular press conferences every day. Jacinda Ardern and Ashley Bloomfield, the Director of Health, they were quite religiously attended. People listened. There was a great deal of trust. We talked about what Jacinda said. We tended to think that we were doing the right thing, and of course, after the second lockdown happened, things, as has been spoken about yesterday, sort of fell apart, and there was a lot more anarchy and anger around it. But in the beginning, there was a high level of trust in government. There was transparent updates on infection rate, and citizens got to know some of the science and talk scientific language. And this open communication was seen in a number of studies to build trust and allow citizens to understand the rationale behind government decisions. A group of us doing work across New Zealand with LSE looked at a number of areas around the imaginations, sociological imaginations during COVID response, and one of the key areas was healthcare workers. And we interviewed healthcare workers, both primary care nurses, Plunket, which is the child health service, carers, home carers, as well as enrolled nurses caring in the home, and mental health. New Zealand has quite a large number of mental health nurses and mental health care navigators who are all interviewed as part of the community care workers. And quite overwhelmingly, although they were hailed to be heroes, they weren't necessarily treated as heroes. Their pay was less. They were often quite invisible because they were working with isolated patients in isolation. Commonly, they didn't get the masks or gowns. They talked about making their own, going the extra mile, going and dropping in pharmaceutical products or extra things for remote and isolated people, and the complexity of managing bubbles at work and bubbles at home. So again, community, there's a lot to be done to really appreciate, make visible, and also give financial support in terms of remuneration and conditions to what's often seen the invisible workers in the community. About 20% of New Zealand's nursing services are community, primary health, Plunket, aged care. We also have a number of Māori nurses working in communities around that. We have quite a strong role for advanced practice nurses, and we have a training route for public health nurses up to master's degrees as well. And they've recently got a pay rise, community workers. Also, some of the other areas for sustainability, we do have a national health platform that enables the sharing of patient data among healthcare providers. And that's only just come into being and seems to be working reasonably well, but there's still issues with remote areas and digital literacy around some of the more remote communities. And many of the remote communities, Māori govern their healthcare, so there's work going on to sort of promote digital enablement in the healthcare organisations that are funded by iwi and hapu money. We also have Innovation Hub that supports the development and implementation of healthcare technologies, and similar to Hong Kong, moving quickly into telehealth, but it brings a number of complexities with it as well, many of which have been well outlined yesterday. Some other legislation was Smoke-Free New Zealand, and I guess one of the things I'd like to emphasise today, and I am aware yesterday as well, in terms of people at the table in this room, NGOs, community workers and consumers, as well as nurses. So this was an example of concerns around high rates of smoking and associated mortalities associated with it. So a nationwide engagement process was started with Māori and Pacific groups, as well as other priority groups, healthcare providers and NGOs, and that includes Māori healthcare providers and tangata treaty, youth NGOs and youth group organisations, research units, including research and academic units, and business and industry. So a number of multi-stakeholder engagement to get triangulated input from all angles to actually promote what would be a way forward with high level of community engagement. This process took up to a year with the community engagement. And as a result, last year, New Zealand passed smoking legislation to permanently ban the sale of cigarettes to anyone born 2009 or after. So by the time those people get to 16, they won't be able to buy cigarettes again. And from what I understand, and it could have changed, New Zealand is the first country to implement an annually rising age of legal smoking through considerable consumer engagement. Innovation, a big part. The Research Grants Councils are very strongly focused on innovation and innovation awards and blue sky thinking and thinking outside the box around what could be done to make a change and develop innovative solutions to current global healthcare challenges such as climate change and also localised healthcare challenges. There is an accessible platform, well, maybe there's a question mark around accessible and more work needs to be done, and social media platforms and attention to multilingual healthcare policies and initiatives, and also the Health Quality and Safety Commission actively involves the public, and every decision making, every particular health bill being reformed or investigation into new health legislation must involve consumers and the public in decision making. We also had a wellness budget introduced in 2022, focusing on social cohesion and social well-being. Although there are questions around how you actually measure wellness. We did feel that was quite a groundbreaking way of putting health and people at the centre of legislation. Just briefly, because it came up yesterday and I redid my slides last night to talk a little bit about this. It's a little bit off the topic, but we do have our undergraduate curriculum in nursing consists of 7 semesters, 3.5 years, of which but overall there's nearly 2 semesters of public health and primary care. There's also a common first year where we have an interprofessional first year where clinical students studying clinical sciences, physio, OT, nursing, podiatry, oral health, have a critical public health courses to look at some of the areas of health systems and critique some of the policies that are happening in public health. And the other topics that are focused on are capacity building, access inequity, social accountability, professional responsibility. And then, of course, we have graduate and master's programs, which build on the principles of the Treaty of Waitangi and is focused on New Zealanders living, staying and getting well. We used to have playing there as well. Don't know what happened to playing. I couldn't find it on the slides. And there's a number of support systems built into that, valuing performance, smart systems, people-powered, etc. And we do have nurse practitioners. These have key roles in community, in remote communities, and in primary health care. And these nurse practitioners do a 1 year to 18-month masters. They can do diagnosis, they can do treatments, they can prescribe a number of antibiotics and also pain medication. They work in collaboration or they work autonomously with population health outcomes. Thanks, I'm nearly finished. And they provide a range of assessment and treatment, and they're also considered clinical leaders. And this is a growing number. We actually are increasing the numbers of nurse practitioners in response to some of the social reforms. And my last slide is just showing you some of this integrated into the new service delivery model, weaving wellness with the family or the whānau as centre, and then the support systems around it, attention to the Māori epistemologies and kaupapa Māori, which is collective processes, specific rural health, and then key population groups in terms of youth, mental health, and all of these, of course, intersect. Chronic illness, aged care, public health, with public health services, hospital services, and social services combined. And in the new interprofessional model of education, we're looking at linking, as I've said, with public health and more of the social work. So we have a practitioner that can respond in a more meaningful manner and more autonomously with helping clients or patients navigate healthcare systems. So thank you for your time and thank you for inviting me. Thank you.